Afternoon.
Hey everyone, welcome.
Welcome. You're in the right place. We've just been battling some technical difficulties. Please just be patient with us. We think we're ready though.
I think we're going to start. We have more people joining, but we love to start. And we want to have time for you guys to ask questions at the end. So it would be a nice thing to have a little time together. And then we're going to open so we can all kind of share the experience together. So Dr. Bechor, you starting with that?
Yes, I'm going to try to control. I can't control the slides. So Yvonne, if you can help us, that would be wonderful. And I'll definitely give it a shot. But Yvonne, can you just test real quick if you can see the next slide, if you maybe press next for us? Okay, wonderful. So please just go back really quickly so everyone double checks that he or she's in the right place. Okay. Good afternoon, everyone. Thank you so much for joining us. Today, we're going to be revisiting a topic that we love to discuss, and it's about basically how to help people who we can call help rejectors, right? Those types of parents or clients that come to us as providers who are generally saying, I'm desperate, help me, it's been forever, I can't get some relief. And then you as the helper provide something, and you can tell already in the relationship with the person that they may not be receptive to your recommendations, or they're being resistant in one way or another. So the purpose of today is to get focused on what kind of parents or clients that we are talking about, and get some really, clear strategies, maybe even if it comes to phrases or questions you can use perhaps to soften that relationship, or to partner with these resistant clients to then get to the goal, which is usually to help the student or the patient. So I'm Michele Bechor, and this is Dr. Katia Moritz. I'm going to have Yvonne go to the next slide real quick so you could see us more. Yvonne, yeah. There you go. Wonderful. So as the slide had said before, I'm Michele Bechor. I'm a licensed psychologist in Florida. And this is Dr. Katia Moritz. Go ahead, Katia.
Me too, everyone. I know some of you guys. We all know some of you guys. So thanks for showing up and visiting with us today. That's awesome.
We're with NBI, Neurobehavioral Institute out of South Florida. And we've been supporting a residential program with a full PhD and all the levels from PhD down for a few years now, especially. And NBI has been around for much longer than the ranch as well. And we do a lot of parenting work. Our model informally requires parent and family involvement because we believe that it's part of creating an environment that helps the skills that we're so deeply trying to instill in our patients generalize, right? You guys probably have met these families where, a patient comes back from a intensive program and then just kind of slides back into old ways. And we're trying to prevent that. We're trying to create lasting change in our patients. So we have a strong parent and family component. We do a lot of intensive work with them within the ranch program. And we're going to just highlight some techniques that we have for some of the more difficult cases. Okay, Yvonne, can we go next, please? Okay, so today we will we'll identify those parents. We'll think about what the red flags usually are, so we are all confident that we're talking about the same parents. And then we're going to talk about how these parents are essentially saying they're ready for change, but actually may not be as fully ready for action as they say that they are. We're also going to talk about how to partner with these parents. And then there is a really strong emotional component for the provider, whether psychologist, psychiatrist, ed consultant. You also have to have this emotional experience in helping someone who's rejecting help, right? And then that's going to lead us to think more theoretically about what help actually means, because I think probably everyone in the audience and everyone presenting as well would identify himself or herself as someone that's in a helping profession. And if we're helping and then we're essentially getting people that are saying to us, either you're not helping or I don't want help in this way, even when they've come to us, we are challenged. We're challenged. These are probably going to be the cases that take up the majority of your time. They could be like 20% of your clientele, but take up 90% of your time. So we'll be able to discuss that more specifically in the Q&A following as well. Okay, next, please. Thanks. All right, no disclosures for us, even though we'd love to have some. Next. Thanks. Okay. So again, setting the stage for these parents. Chances are you already have some in mind. For the most part, it probably would be a patient or parent, I should say, that's like one of the most difficult parents that you've worked with or you're currently working with, or ones that you've just said to other providers, I can't provide. I've taken them to the last place I can take them and I can't keep going. So essentially, it's that when people are help seeking, they can accept or reject, and they can accept help if it's going to be functional for them, or they can accept help and it's not. And they can also reject help and it can be functional for them or not. And we're certainly focused today on group number 4, that they're rejecting help, but the recommendations they're rejecting would actually be functional for their families. So again, that's the model we're looking at. And on the next slide, we'll talk more about red flags. So Yvonne, please, yeah, next for us, thanks. Okay, wonderful. So who are these parents? Okay, parents that may be presenting with urgency, end of the world type urgency, or telling you they've seen a lot of providers, or trying to also get that last extra minute of your attention. Sometimes they also will tell you other providers were never good for them, or they're also very, very new. They could be. They can ask a lot of questions. They can focus on the small picture. And sometimes they're considered hot potato cases, or ones that either fill the paperwork so much, fill to the brim with paperwork and detail, or don't really fill out paperwork at all. And for the most part, they're ones that, again, are more these red flag cases saying, whoa, 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 we'll do anything. We'll do anything to change. Please just help us. Please just give us that magic answer, right? And so they're ones that end up taking lots of time, who may also pull apart your own recommendations and essentially are saying they want to change and fully do see a problem at hand in their home, and then essentially are not really acting on it or telling you something's not okay with what you are providing for them. Okay, next slide. Okay, so we have lots of explanations for why these clients may be how they are. I'm not going to go through all of them with you, but they are all listed here. And we'll just pick apart some of the ones that we've seen a lot. And this is, our team coming together, some of our teammates being, decades in the business and telling us what may be accounting for this, right? So more often than not, we're going to have patients, meaning the child patient or the young adult patient, having a lot of disordered behavior, right? In our case, it could be OCD or anxiety, eating disorder, personality disorder. And then we're essentially working with their parents as far as placement. We'll also notice sometimes that there's either a whole family history of problem behaviors and or diagnoses that are common in the patient and then in the parents as well. There's also, there could be just general ambivalence. There could be bad experiences, general mistrust of the industry. There could be even their own just right experience, just wanting to make sure the most perfect condition ends up around their child all the time. Could actually be financial. Can also be levels of knowledge, right? There are some parents that, as you can imagine, worry sometimes, and the worry kind of flares up and they tell you how concerned they are, and then they may not be ready for action. And we kind of find out the hard way sometimes as providers. So take a look at the list, see if any patients maybe that you're thinking of, some clients you're thinking of may kind of match up with one of these explanations. Again, this is one way that we all can make sure that we're talking about these parents that are particularly challenging. Okay, next. All right, awesome. So what's up against us as providers? Again, we have a whole list. We won't go through the entire thing, but in general, the takeaway from this information here is that we are trying to manage a lot of stigma about mental health. There are some elements in social media right now, or Netflix, for example, where a lot of programs are being portrayed as really negative, and there's a lot of mistrust then of the industry, like we said earlier. So sometimes also parents have unrealistic expectations for us, or there's this general crisis in confidence of the institutions out there. They don't know what they don't know. So they're generally really doubtful. And then we can be sort of the representation of the problem or the face of the problem. And as we're going to explore more, the problem that we're all up against, again, with providers and our clients, is the child needs some help, or the family needs to change, or a program can be a good fit for a young adult or a child. We're up against that they don't know how it's all going to pan out. And so again, at one level, we could be maybe the face of what they don't know. And sometimes we have to be the ones that may absorb some of that, let's say, distrust or uncertainty, and really learn about our patients or our parents too, what the level of tolerance of uncertainty actually is. So yeah, many, many reasons why we have things up against us. All right, go next. Okay, so now what providers don't know. So in doing more of a deep dive into literature, especially in the level of efficacy that some recommendations actually have, right? Basically saying, do ed consultants and psychologists and providers give recommendations that end up working when it comes to placement? And we're noticing, on a more sour note, that there isn't a lot of research out there. You know, we can look into NATSAP's literature, other literature. We were just at NATSAP this past January discussing this very problem. There isn't a lot of formalized research on whether our recommendations are efficacious. You know, we might have word of mouth, or we might have like our own anecdotal information to share, but this contributes to the problem. We as providers don't always know if what we're going to provide is going to be effective. So do we make good recommendations? You know, we like to think that we do. We have a lot of success stories, each of us, and we're still really not sure. So again, it's underlining perhaps the mistrust or that level of, you know, conflict that there is with newcomers in our industry. Next.
And Michele, if I may add, you know, we don't make recommendations for programs, right, that ed consultants do, but we make recommendations for treatment, and we make recommendations for next steps. And so we actually face very similar issues. And our goal is to kind of share our experience as clinicians, living day to day to day, minute to minute with the patients, to help us understand how that process is similar. It's similar when you are recommending a specific piece of intervention, also a full intervention. And so we are, you know, kind of learning from that experience every day, in the moment with the patient and the families, and which we are going to try to translate that experience to the ed consultants that make, because we don't make those recommendations for programs. We don't say, oh, where you go, how you go. We make recommendations for the ed consultant to do it, right? They were sent to ed consultants. And that even gives us the same experience, like, oh, why do you want me to talk to this person, not that person? So I think it's pretty great for us to talk about that.
Sure. So there's that mistrust in the industry, where we're presented with a lot of, just again, what people don't know, and that they could be scared or up against a whole litany of things that make it hard for them. And we're trying to shepherd them through this really difficult process. So we want to talk about help rejection. It's a term we're going to use throughout the presentation. Help rejection in a larger context, because in the smaller context, you have client coming to consultant or client coming to therapist and saying, hey, we're struggling, how can you help us? And then essentially the provider gives recommendations, as we're trained to do. And usually it's based on, you know, with best of our knowledge or best of our experiences. And essentially we're getting either someone picking apart what we're saying, or just taking it and not really making any significant change. And we're very aware that most of the time our young patients or clients, they need to have an entire family systems change. Not always, but it would help for their skills, their new skills that they may get to last longer if their context changes. So essentially we're trying to say a whole family has to change. So the help rejection part of this, it's just so important to highlight that when there's help rejection, it may not be a reflection of the provider's abilities, even if it can create some doubt in you as a provider. If you're getting some pushback, or you're just getting that they're not changing at all, or they go to another provider, come back to you, it's like over many months or years that they're coming to, it may not be about the actual talent level of the provider. I mean, it may, and for the most part, we like to keep in mind that we could just be providing recommendations as we're trained to do, as we're paid to do as well. And it may not always pan out or be the right time for that family. So we essentially represent long-term change. And one thing to consider too is if we have families that are characterized by long-term, let's say, dysfunctional behaviors or long-term tendencies that have led to this, it's probably even bigger of a challenge or harder for them to change. We're going to people that have been doing this for so long in one way and saying, well, we can help And the helping is in the form of something that's very difficult, which is change. So we are sometimes the messenger, right? We represent that long-term change that may be at least seemingly impossible. So because we have to decide where the limit is as far as what is help, we also may have to decide on contingencies for us as providers. We may have to present with conditions under which we're going to actually create care or placement. For example, I will work with you guys once, mom and dad go to anger management or couples counseling, because you can see that they may need some even services before they're ready to even hear recommendations, or basically ready to change. We also say have open discussions about goals and partnership. If, for example, you provide help and you're sensing maybe you may even fall into the helping trap, meaning you provide, they say no. You provide more and better, they say no again, and you feel kind of like you're chasing after them and you might want this more than they. You can also say, let's talk about what's happening. Let's talk about the process. Hold on, guys. We gave you this, we gave you this, we gave you this, and here's what happened. You can always take a step back and say, let's really talk about what we can do here as a team. And we'll talk more again about how to partner with the parents. There's also a particular approach that could be paradoxical, which some literature does point to. So that is to say, well, you can always continue going on the way that you are and just sort of explore with them what that means, just so that they kind of are led to deciding or thinking, do I really want to continue going on this way if I really do need the help? So overall, what you're looking for in a client, of course, is that readiness for change. So a very important variable in here, and one thing that we want to explore the most today, because readiness for change has different stages, which we'll talk about. And if someone is saying they're ready but not acting on it, they're in a particular stage. So then we as providers have to be aware that we can support people in all the stages of change, depending on what it may look like and how we sort of deliver the message. All right. There you go. Okay. So what we can do, right? If you guys have, obviously heard of parent training, what we can do, especially we as providers, meaning NBI and related clinics, we can provide an in-depth parent training service. Ed consultants and psychologists can do this as well. They can assess the parent and family dynamic, and they can get support from therapists. So in other words, this is more about parent training, where we want to support what parents know, whether about the disorder or about the process itself. A lot of parents benefit from just knowing how the ed consultant process works, either before or during their engagement with an ed consultant. And then we can also work on teamwork among the parental unit. Most of the time in families where they're doing a lot of help rejection or there's a lot of long-term lack of change, there's a lot of discord in the unit, especially the parents unit, because they're leading decisions and they're often stuck because one wants one thing with one style of parenting and the other one is really, really different. So we work on communication skills for parents to one another and also parents to children. Also, how they may, have an understanding of behavior changes. A lot of times we may have met those parents that are accommodating or buffering or removing difficulties from their children's, let's say, development or their path, and they think they're helping in the moment. And then they don't know. So often they're not even aware that they may be stepping in and making some of the dysfunction continue. So again, having them have knowledge of, let's say, behavior modification or what it is to buffer, what it is to accommodate, and what the long-term effects are. This is how parent training can influence how parents may function and possibly make it easier in the matching process. And eventually, too, we want to maybe expand the list of caregivers to maximize generalization. So if nothing else, parent training can get parents on board to be considered like clinicians or on the team of the child. Instead of just kind of coming along, it's like, no, we're the parent trainers. Let's have you guys collaborate with us, whether for an intervention or for thinking about the options, or if parents have to be there when, let's say, a young adult client goes with an ed consultant and starts to learn about different options that were narrowed down. We want to actually strategically involve parents, not that they're doing everything for the young adult, and also not that they're completely in the dark, right? They have to be involved and feel that they are collaborators. And again, we don't want them to do too much for their children because we want those skills to increase in the children. Okay, next. Oh, Yvonne, yeah, next one if you can. Okay, good. So again, these are some core elements of this specialized, tailored parent training that we've seen prove pretty successful to help facilitate the ed consultant process. And so, for example, we work with parents to think about resilience and long-term gain for skills that their children may not have, and what it may take from parents, whether it takes actual change on their end just to increase the resilience in their children. We have a lot of talk about that in probably all of our parent training cases. And we also work on their understanding of acceptance, namely that acceptance and approval are not the same thing. And it's easier said than done, of course, right? It can be someone has a chronic illness and this is how you have to readjust and support them 5 and 10 years from now. Or it can be that someone's having a crisis and you have to just accept it and consider what emotions could be accounting for you doing things that aren't working for your child. Also, we work with parents to think about empowerment. And if it takes, let's say, some separation at the time, or just to validate a strong emotion and ask the child, what do you want to do? It can make quite a difference, even when children are presenting with, let's say, suicidal language, not so much behavior, but they're just so desperate, they're so depressed, and there's a lot of, let's say, fighting or issues that come from the rescuing. We talk with parents about whether they're interfering with the learning process of the child in treatment. And it ends up mainly boiling down to whether there's a parenting style or parenting beliefs that are making it so parents are essentially stepping in and they're kind of slowing the process of treatment and development down. And then that does marry well actually with the level of expressed emotion in a family, because we'll find a lot that if, we meet, let's say, a family where mom and teenager are arguing for 4 hours a day, obviously something needs to change. So we talk about whether parents may have to monitor their own emotions. And no, parents are not our patients. We just consider them as part of the environment. So we work with them as much as possible, either to partner or to just have them decrease reinforcement of a behavior that we don't want. We essentially look at whether a behavior is taking place in a home. And then we work with parents however we can to have them influence how behaviors are reinforced or not. And then that,
Michele,
of course, has a lot of implications. Yeah.
Is a little like, if I may add something, I think that's really important for us to recognize is that, the treatment and the interventions for patients with anxiety is sometimes a little different than for the kids who are showing overt behavioral issues, drug, alcohol, and all of that, and the kids that have ASD and OCD and anxiety and all together, because the parents' experiences are very much, I feel so sorry for my child. While sometimes with other behaviors, parents are like fed up and feel like, okay, something needs to change. And I think the child's suffering is seen differently when a kid has like all these conditions together, and anxiety is a big piece. Because one thing that is terrible, if you guys all have experienced that, if you have someone next to you struggling with a lot of anxiety, it makes you so anxious. It's so difficult to manage ourselves that it's even hard for us to implement. It's much easier to say, oh, I'm angry, my kid is, spending all our money on drugs, and now I have this kind of like motivation. But when you see your kid freaking out and not doing anything quote unquote wrong, then it's just a much harder parenting training. And that's why we say tailor the parenting training to the case. And even when we get parent trainings that are not our patients, just a family comes in to get ready to make a placement, we have to understand that those parents are going to function very differently than other patients, the other parents. I'm sorry, that's what I meant.
Mm-hmm. Yeah. In our parent training, we often find that we have to try to stop parents from doing what seems warm, right? Like they're driving their child if the child's too afraid. They're trying to bring the child's lunch to school if the child forgot the lunch because he was, let's say, anxious for a test, and it becomes excessive. And essentially they're being really warm and protective. And we have to actually just talk to them about why being too warm actually interferes with the child's learning or development. So we have to, again, be the bearer of bad news. And we notice that in this process, doing that is such an art. And so we're like, we bring the science and we try to bring the art as well. And we'll talk more about, again, how we find that it's about relationships. Actually, yeah, Yvonne, please go to the next one. It's about relationships. We're noticing that with resistance, you might hear something like roll with resistance, right? Partner with someone against the problem. We're essentially working with the population that want change and are unable at the moment. Or think about smoking cessation or weight management. people who want to change and talk about it and want everything about it, but then just don't actually act on it. These are our clients when they're pretty difficult for us. So we want to avoid help rejection. We want to also be with them, not only be the messenger who, not just doesn't get shot, but the messenger who grabs their hand and says, hey, let's look at this in bad news together. And then think, okay, look, we have to be united against the issue. So all of these elements about how it is about the relationships and how we don't want to lose the clients who basically need us the most, we wonder for ourselves, okay, does the form of help depend on the level of readiness for change? So in other words, we have to ask ourselves, what is help? We'll see later as we go, but we're going to basically say, is help given if you even help someone identify how ready they may be? So we'll bring a little bit of the scientific literature in just to kind of inspire some conversation, because there is a lot of literature and research on change, behavior change, and motivational interviewing, and this is one of them. It's the stages of change model. And the idea here is that in everyone, for every particular behavior that they're wanting to change, they can be in a particular stage in a cycle. And it usually starts with pre-contemplation, where they're basically becoming more aware that there is an issue, becoming more aware. And then they could be in contemplation, where they're saying, okay, there's a problem, and I'm thinking of what I'm going to do. Then they'll go into determination and actually choose what they want to do, but they still may not have actually done it. And there's the action stage where they're actually making the change. Someone in the action stage is, let's say, going to the gym regularly or eating differently or stopping with the cigarettes, right? They're actually making the change. And sometimes there's relapse, which is actually part of the change process. And then there's actual maintenance. So as you can imagine, the parents that we're really referring to, the ones with the red flags and the ones that make us kind of feel exhausted or make us doubt ourselves, are typically in pre-contemplation. They're aware there's a problem and they're still considering what they're going to do. And they can go to contemplation and slide back, right? We're typically working with people that are saying they want to change and they're engaging in our services, and then we're not seeing actual change. And this can kind of be like a long-term pattern or part of their own deficits, right? The same things that got them to need to change are probably the same things that are continuing and making the change harder to implement. We'll come back to this. Okay, let's go to the next slide. Okay.
Well, so our job was to set this up so we can actually talk about the real problem, and it is a problem we all experience in our world of, clinical and placement, is the fact that we know sometimes when a patient or a parent or a family is going to be trouble, right? Next. And we see, you could go next, Yvonne, that's good. We see that some of those behaviors are very much you're going to interfere with treatment. And we do see early in the case. So many times, even the way they call us, the first interaction tells us. And we actually have experienced that with other providers. Sometimes you talk to a psychiatrist and you feel like they do those interfering behaviors in the relationship. We have had consultants that do that too, and we have clinicians like us that do that as well. But you have a little idea at times that those things could really create a problem, right? And so we know that there's trouble when you get people triangulating and trying to pitch your staff and other people and other providers and say one thing to one person and the other, and then start to move the relationships in a kind of a flipping and it's trying to create kind of conflicts, right? We also have families that make threats. All of us, I mean, we all experience that emotion dysregulated and crying or avoiding us. Some people cross boundaries. They think that you're responsible to talk to them at all times, and you don't live, right. You need to be with them, and no matter what, it's a lot more than you expect. And I always say that when you have this feeling that you can't end your sessions goes on and on and on, and your hours are consumed by those families, it's very hard. We also talk about flipping. When you think things are going well, all of a sudden you hear something you never expected to hear, right? And sometimes the opposite. When you think like, no, this family really doesn't like me. And then you hear, oh my God, they love you. And you're like, what? Like, no, it's very confusing. And also like this expectation of outcome, you know, and repeating to us what we said to them, but the context is totally different. So they have an expectation that we can deliver something that doesn't exist. So they're mad at you because there's not a program that is exactly the way they imagined there would be. It's like you are the one that didn't create the program for them, right? And then, you know, and then you say, you told me that there were programs like that, and then the program didn't accept their kid. So it's, you told me what, you know, we told me what's going to happen, but you know, we can't control that. Next. And then we become villains and heroes, right? And so that's a really interesting experience. All of you probably already have experienced that before, where all of a sudden you really worst person ever, or all of a sudden you don't even know, because you know that they are making you so big and so heroic and so perfect that you can't deliver that. That's an impossibility. So, and both, you could be both hero and villain at the same time, which is very confusing. But all of you this presentation have felt that way, where a parent was saying, you're the best, I can only work with you, and then all of a sudden you're the worst, right? And sometimes you both at the same time, which is very hard. Next. So I think that that is an experience that we all have, and I think that in order to talk about the feeling that we have and managing this, is very important for us to protect ourselves. You know, the families that are rejectors are also demanding, and they also make you feel like never is enough, right? Many times they're looking for a silver bullet. I don't know, you know, you guys probably have experienced that in the past, where you were explaining a concept and the parent said, did you ever tell my kid that if they use drugs, something bad will happen to them? As if my saying that to your son is going to change the course of everything. And almost that there's one thing that we have missed to say that was the thing that will make this behavior change. So there's like this auditing feeling of like, what have you not done? And it's very interesting. It's like almost like a naive perception of behavioral health, mental health issues being a very simple issue. But it's, you know, as we know, it's not, but it's kind of like a very specific parent that says that to you. And that's the parent that usually is taking a lot of your energy. Also, sometimes they're funny because they don't show up for the things like, so we say we have extensive parent intervention for the families, and those guys don't show up. And you're like, wait, aren't you the person who needed so much help and was asking for so much help? How are you not showing up? Oh, I'm busy. You don't understand. I'm busy. I'm like, we do, but like, we need to work on this together. If that's a priority for you, like you said, we have to make this a priority, right? I also say, like, we have a big team, about 45 people working together. And I could see when we have a few of those cases at the clinic where the energy and the exhaustion and the burnout is really happening. And we really need to be very mindful of that, because I'm sure you guys working with families have that a lot. You know, it's too much time, it's too much energy. And then you manage the threats, right? How many times I'm leaving, I'm not coming here anymore. I love that. I say, please do us a favor, leave. That's a great thing. Threats that they're gonna sue you if you don't do things the way they want. I had one that was really interesting. Unless we did the treatment the way he wanted to go on the news and tell that we didn't do the treatment for him the way he wanted. And he was gonna go to Best Business Bureau and make a claim against us. And I was like, look, you do what you need to do, right? So this threats is a really interesting kind of process, and how we have to manage that, because our reaction is always what we have, the only thing we have. We can't came to those families and give in, right? Next. So I do think that as a provider, and you know, we supervise a lot of our clinicians. So as a clinic is interesting because, you know, we still are doing 100% of the work. It's our clinic is owned by us, and you know, we are there, and working with our staff and clinicians, and we could feel that the frustration and questioning. I mean, am I really good at this? Can I really do this? You know, the auditing of the work, like it's an interesting thing. Not that the parents don't have a good argument. Oh, you guys forgot to call me, but it's minor little things. Like in the big picture, you did 1,000 things for them, and the one little thing that didn't happen the way they wanted, they just right there to your face. You guys are terrible. Nobody called me at this moment and told me exactly this. A million things happen in a day. We really can't tell you every second. We do the best we can, and the idea that the team is doing the best they can, going above and beyond, and the families sometimes are treating them this way, it really sucks the life out of the clinic. And I'm sure it sucks the life out of you. So our goal is to help you prevent that. Next. I think that it's really important that we predict our feelings to work on our actions, right? So I think that we have to know ahead of time. So we need to understand when we hear a family and a structure, we need to have an approach. So I'm going to share with you guys my approach and the approach of MBI. We do a lot of interventions for very complex patients that are not in the drug space. So interventions for kids with anxiety are very difficult, because if they're like homebound, ASD, anxiety, and all of that, parents are feeling sorry for them. They don't want to help. And doing those interventions are hard and really touches you a lot. It's very difficult. So we have to help ourselves cognitively restructure and accept how difficult and what the steps are going to be. But also we may need to do that for parents. And I want to give you a few hints on how to do that for parents. Next. Right. So I like the Eminem song, Tell Me Something I Don't Know About Me, the 8 Mile battle. It is like, I actually started my clinical conversations with parents like that I know are going to be a problem. And I say, look, clinically, we're outstanding. Administratively, I think we have problems, and I know that you're going to find them. So what we do is we go ahead and just tell them before they even find the problems, because once they do, you say, I told you. I mean, maybe this is not the right clinic for you, right? And so that conversation is very important. Also, the ability to predict what comes next, and that's something that we need to help people in general. And sometimes we get a lot of the folks that are trying to do an assessment to see where they should be going to treatment, but also getting their parents kind of prepared for that recommendation from their consultants. We need to predict process. I love to predict for people, under wilderness, there may be more treatment necessary, because most of it, wilderness is over. And so helping the ed consultants have to deal with that aftermath, because I hear that all the time, right? So we need to look ahead and actually set it up right now. And I like, if you ask people, do you want to be good partners with your child's treatment team? They say, oh my gosh, that's everything I want in life, right? But no one really tells them what to do to be a good partner. So what does a good partner looks like? What do we need to do in order to be a good partner, right? And also, it's very important that we address with the families the symptoms that are going to affect this outcome. So sometimes it's the parents' own difficulties, and sometimes it's this child's own difficulties, right? So if you have a child that is very manipulative, and your child knows how to play on the parents' heartstrings, I need to go ahead and set this up. I have to set that stage up and say how the anxiety symptoms are going to manifest themselves when we're doing an intervention. So we need to have the experience and call it out what we do. Next, please. First thing that I like to do is that I want the parents know that they know their child's best. And a lot of times when you're trying to make recommendations, the first, you don't understand, you don't know my child, you don't know my problem. And I always like to say that that's actually very true. That's why we need to partner on this. I know your child's condition better than I know anything else in life. And this is a time for us to talk about how to help the condition. And the child is the framework here. And we want from you what your child is, but and what they need, in your opinion, but we also are the specialists, and we need to help you understand that it hasn't worked so far, and there are some things that we may need to change, right? And then actually go down to what it means to follow recommendations. But I think it's important to actually let them know how it's going to feel first, right? So if I have to make difficult treatment recommendations, it is important to lay out how that is going to impact them personally. This may be against their own family values. She Hispanic and Latino families. I'm Brazilian, so I speak Portuguese and Spanish in our clinic. A lot of us do. And in that group of people, you have to really set up a lot different than you do for an American family that lives in the U.S. Now, those families really function very differently. So it's very, very important that we understand the cultural differences. But in order to explain how to follow treatment recommendations is actually before you even follow the treatment recommendations, right? The other part is I always tell families that your child is not a project. Your child is not a clock that we're going to take a piece, fix it, and put it back together, and things are going to tick perfectly, right? Your child is like a class. It's a lot of this together, more stages, and we have to partner in understanding what that is and how to make this treatment possibility better for them. And then we lay out the partnership. So what I recommend very often to consultants is that if you have a very difficult family, our experience has been with them that if you tell them exactly what a partnership look like, what are treatment interfering behaviors for us. So in a case, placement interfering behaviors, how difficult it is to make a placement, what does a placement looks like, how do families usually feel about it? Those very important pieces of the placement for us personally. When we work with we bring an consultant come to us with a referral. I know that referral is well set up, and the family understand the expectations and how to partner with the program. The families already know that there are things that they can do to make the process better for them, their consultant, the child, and the program that they're initiating a relationship with. So I love that when people talk about that is really important. And also I love to help the people making the placements understand deeply the conditions, because as they do psychoeducation, and you guys do psychoeducations all the time, that psychoeducation is a huge part of the job you do. When it's a specialized type of care, families feel much more confident when the consultants really understand what's happening and details about their condition. Next, please. And we are going to open this to conversation with you. So we always like to ask the people, like from 10, how much do you want this outcome, right? And then we follow up the question of from 0 to 10, how much are you willing to do the things that are necessary to do in order to get there, right? So the question is, how much do you want this, and how much are you willing to do what you need to do to get there, right? Very similar to any big changes and big endeavor you have in life. It's not about like, oh, I want this. It's I need to be willing to do this sacrifice or to learn or to challenge myself like I've never done before in order to get the outcome. So families that are facing with placement or treatment are very much in that position. And what I think is that can help be ready to change, right? So many times people say, well, this family is not ready for treatment because they can't figure out where to send their kid. And the question is, maybe what we need to do is treat them for readiness, right? So how do we help someone who's not ready to make that change find reasons, find what's not working, find how to manage that distress when they see their child distressed. So then when they have to make a move, they're ready for them move. And you're asking people to do some of the most difficult things they have ever done in life. And we all know that if they don't do, they're gonna go through the worst, most difficult things that they ever done, been involved with in life. So our job is to definitely try to go ahead and figure out a way as consultants, as clinicians, to be okay that the help may be to just help them get there. And then the process, you guys know better than we do. And I'm going to open that to questions. And